So, my name is Abbas. I'm one of the vascular surgeons. Our group is currently 9 physicians. I don't know if we're going to expand in the future. I'm talking about the surgeons only. Otherwise, we have APPs, we have vascular medicine. So we're a big group. But the whole concept is to make it easier for access patients to have maintenance of their access. What we're doing in the first stage for now is only maintenance of an access, not creation of an access, not doing surgeries. Nothing involves anesthesia. Essentially, we're doing what we do in the IR suite or in the cath lab, which is essentially the physician does the procedure, and the nurses introduce some mild sedation medications like Versed and more, fentanyl. Nothing that you guys can't give on the floors under your RN license. So, and these are done everywhere in the cath labs. We have what we call OBL, outpatient labs, and these are done for these procedures like lower extremity angiograms, fistulas. So what we're doing is mainly fistulograms, angioplasties, and percutaneous thrombectomies. When you think about thrombectomy, you probably think making an incision. Nothing entails this stage is making incisions or cutting or anything. It's all percutaneous. The whole concept is to make it easy for the patient, the nephrologist, and the dialysis center to just pick up the phone and call us. We have a problem with an access patient, or like either thrombosed, or we don't know what's the problem. We have this problem. We have an swollen arm. We have a high venous pressure. We call it high venous pressure. And usually what's done is, okay, we'll schedule the patient for a percutaneous thrombectomy or for a fistulogram and possible angioplasty and these things. What our competitors do, and they are very efficient in it, and Paula knows it, and that's on our office. The part where the dialysis center call or the patient or the nephrologist call is on us. It's on our office, and this is logistically is being worked out in our office by Paula, Andy, me, and other people in the office. Your part is to bring in the patient like you do in any procedure, prepare the patient, take them, do the procedure, and then it's the whole process and I've worked in these centers outside. It takes the whole process of bringing in the patient, takes about half an hour to an hour. The patient goes to have their procedure done, and they come back and they recover for another half an hour, and then they go home. And this is what patients like. They don't want to go through the hurdle of registration, sitting for hours, NPO for hours. They don't want that. If we put them through these hurdles, there are a couple of centers in town, not very far from here, that will do a good job in doing that. And I've seen it because I've been involved with these. So the procedure, like I said, they're not difficult procedures. It involves a lot of sheath and catheters and balloons and these things, and this is where these gentlemen will make it affordable for our center. And that's worked out between them and ProMedica. That's not between me and them. It's between them and ProMedica and Paula and the entity, the institution. Okay? Any questions? Anything? If I can answer anything.
Besides the sheaths and stuff, what kind of instrumentation are you looking? Is it just like a small tray of stuff,
It's usually, there is a basic tray, which is very basic. Like I said, you can talk to IR, you can talk to the cardiac cath. We have a vascular room in the hospital that we do these things in. And you tell me, well, why if you do them at Toledo Hospital, why don't you keep them there? And this is a very good question. The only thing is that patients, nephrologists, dialysis centers, and the patient especially like the environment where they don't have to go through the hospital thing. And you know how many times patients go to the hospital and they're either late, they stay for 4 or 5 hours, and the issue, they go through the hurdle. So this is what we're trying to bypass by doing it here. And this is the perfect setting for something like this. It's not, trust me, there is a basic tray, and then the rest is wires and balloons that these gentlemen will help you setting it up, or will help you whatever we need. Whatever the surgeon, they know what we need for these procedures. They've also, by the way, they worked with these other competing centers. So they know what we need in a setting like this. And we know what we need. Usually, I know, first we're gonna start with 2 physicians, me and Dr. Oriolo. But we're hoping, we have, I think, 4 or 5 that are willing to get, but we're gonna start slow. See, get you kind of trained to the process, these things, and get everybody comfortable with the process. And we see also how much patients. We're thinking that now, if the process works well, every fistulogram patient, we're gonna guide them here. So essentially, we're probably gonna reach a stage where only the very difficult fistulogram or the very difficult thrombectomy will stay in the hospital. The rest will probably be concentrated here. So it's a slow process. We don't want it very slow, but we want it slow for everybody to get used to the process and to get used to it, and then fire it up a little bit more. Go step by step, adding probably in a month or 2 or whatever we decide, add another physician and another physician until we're covering at least 4, if not 5 days of the week. I don't know if I'm accurate.
That's right.
So the things that you might want to know is that as an RN, there's nothing we're going to ask you that is outside your license. Like if we ask you, usually we tell the nurse 1 in 50 of 1 milligram of Versed and 50 mics of fentanyl. These are not outside your scope. These are given when you call a physician in the middle of the night. Oh, Dr. So-and-so, the patient is in pain. What do they tell you? Give them 4 milligrams of morphine or 50 milligrams of 50 micrograms of fentanyls. There's nothing outside your scope that you cannot do as a nurse without anesthesia. And this is done everywhere. So it's not beyond the scope of your license. The other thing is you might have to give sometimes like Benadryl. Also, it's not outside the scope of your, for somebody with allergies. For somebody with allergies, usually our office will prepare them, like we'll tell them take that much prednisone or something. We can give also shots of Cilamadrol on the table if it's needed. So these are the things that I'm thinking of. Like I said, you don't have to worry about any medications. All the medications that we ask you to give as RNs, it's not outside the scope of your license.
Do you give them anything oral to take before they come to the facility?
If it's prednisone, like we tell them,
They have a diet, we have a 24-hour prep that we
Okay.
do, that we will.
we have a prep, yeah.
And
Okay.
we'll call the prescriptions in for.
Do you ever give them like Valium or anything to take before they come?
The what?
Valium or anything?
Not really.
Okay.
Not really.
Okay.
I mean, the Versed is the IV shot of Valium.
Yeah, right.
So they're gonna get it on the table.
Okay.
And I'll be honest with you, what I do usually, I don't know about other surgeons, I don't even give anything in the first shot. When I first do the fistulogram, get an access, and I use the micro sheath, I don't use the big sheath, and I don't give anything except the lidocaine local. It's, when I start, when I start with pure local. If I want to do intervention like angioplasty, then I tell the nurse, okay, and I usually give it myself because I have the access already. So I tell them, put it on the table for me 1 milligram of Versed and 50 fentanyl, and I usually give it.
Okay.
So I end up about 70–80% of the times, I end up giving the medications myself.
Because you have the access.
Because I have the access. I usually, and this is what patients like. They don't want to put up with IVs. They don't want IVs. And when you get access into the fistula, you already got access into the vein.
Okay.
So we usually, I give the way I do it in the other outpatient center is I shoot the fistulogram and I tell them, okay, I'm gonna intervene. And they immediately know, so they put the milligram of Versed in front of the scrub nurse, 50 fentanyl, and the heparin. And I give all of them. And then I intervene.
Okay.
So really, in my case, about 80% of the times, I give it myself.
Okay.
And they don't put IVs. And patients love that. They don't want to be, because these patients don't have veins. And this is one of the main things that they hate about hospitals, is that because they go through the hurdle in recovery or pre-op area, they want to put IVs and blah, blah, blah. I don't. I tell them, don't put anything. Just prepare the paperwork, which shouldn't take more than a few minutes, and take them back.
Okay.
And usually I get an access with a microsheath, and that would be my IV access. I give all the medications.
Okay.
And so, it's, and they love this. The patients love that,
In recovery, so I'm gonna let them go home, about 30 minutes, they'll be immediate access, they can go to dialysis like immediately if they need to do
Yeah,
that.
they can, yeah. This is the good thing about percutaneous, is that they don't have to, it's not cutting, it's not, trust me, the less steps we take, the more patients and dialysis centers will like it, because they want, I'm having a problem with the access, bring them today, tomorrow morning, get them done, go back to dialysis, boom. That's, this is for fistulogram. For permacath removal, I don't even, I do them like, it takes me literally about 5 minutes to do a permacath removal. And it's only purely lidocaine. I don't get IV access for permacath removal. I used to do them at UT, I used to do them in my office, in the clinic office. It's a little bit, we used to have a procedure room and these things, but here it should, permacath removal takes about 5 minutes. Fistulograms, I don't know what other things, am I forgetting something? Thrombectomy is
probably.
yeah, the most complicated is probably going to be the percutaneous thrombectomies.
Can you go
And
through
still
that
with-
procedure?
huh?
Can you go through that procedure?
Yeah. Do you have a board to draw? I'd like to draw. It's, yeah. Well, the access usually, I don't know, do you guys know what we're talking about, the AV graft or AV fistulas? Okay. So usually the access is from an artery to a vein. So let's say the access is like this. It's a tube under the skin. What I usually do is I usually stick the graft here, put the sheath in, shoot a little bit of a venogram and confirm that it's clotted, that there's clots. Then go with a wire and go with a catheter, and then I would inject medications like heparin.
How much heparin should we have in the room for you?
Usually for me, I like give 4,000, 5,000 units. So I give the heparin through the catheter. And then sometimes, once in a while, I inject TPA like 2 milligrams or 4 milligrams maximum. I don't think Walker uses TPA. Sometimes I use TPA, sometimes I don't use. What I do it is I angioplasty, I kind of smash the clot. Dr. Walker uses a Teratola, which is essentially a device that swirls and make the clot like a smoothie, and just kind of break up the clot and flush it so everything is going into the lungs, which is not a big deal. It's like smashed, it's not a big clot. So this is the venous side, then we put another sheath like this and we go on the arterial side, and I usually pull out the clot with a balloon, over a wire, forwarded balloon. Of course, we'll get you that one. And we do angioplasties and these things. So it's usually the Teratola, angioplasty balloon, and forwarded balloon that we need for a thrombectomy, for a percutaneous thrombectomy. And then at the end, when we pull out the sheath, we just put just a small stitch at the skin level, like a figure of eight, something. It takes 2 seconds. And everything is all set. So usually it takes about an hour usually. I don't know if I'm talking about my experience. I don't know about the others. For thrombectomies, I might come to help Dr. Oyo on a few ones, the first 3-4 ones. I don't think he's done it as much as me and Dr. Walker, but it's very easy to just take off. It's not very difficult, and that's the most difficult and most involved of the procedures that we're going to start doing. The rest is angioplasty, is angiogram, angioplasty, stenting. These are piece of cake.
But we'll have reps here with us.
Yeah, I think they're going
You'll
to
be
be
here
here.
for these procedures?
Yep. Yeah, at least initially. Once you get moving on these, they're
Yeah.
pretty simple.
Once you
Like
see,
a regular
yeah,
angioplasty, like he's
Yeah.
talking, might take Dr. Abbas 20 minutes, half an hour.
mostly.
So when he says angioplasty, he's getting, when he gets access, he's doing that with an 18 gauge needle. So we're just going through a little needle hole.
Yeah.
And a wire goes through that, a sheath goes over that, and the sheath protects the vessel, and then allows us to pass these balloon catheters and things like that in that. When typically we're just looking for a little compression area. He goes in with a balloon, he blows it up, compression goes away, and we're done.
And sometimes we put a stent, sometimes we just.
Are we gonna have, like in the hybrid room at UT, we had like a bazillion choices of
Well,
wires.
this is
balloons
Kelly, don't,
and-
it's, like I said, I know you're used to the hybrid rooms. And this is the good thing about these, but also we have to be proficient in what we use. And this is what makes these outside centers successful. They don't bring things unless they use them frequently. If somebody needs something exceptional, either they tell you ahead, bring me this and this, or they just don't do it here, they just do it in the hybrid room in the hospital. So no, don't think about what we do and yeah. Well, we're gonna have the things that we use most frequently.
Sure, makes sense.
Exceptional, it's either not done here, or if it can be done here, we will tell you ahead.
Hi, Trina.
Any further questions? Sure.
Hi, I'm with sterile processing, so I deal with your instruments.
Okay.
So at some point, I would like to get with you and your other doctors so that we can kind of dumb down just what you need, so we don't have a ton of things unnecessary to you, okay? We just want to make sure you have
Sure,
exactly
sure.
what you need.
Most
for your
of what we
cases.
use is disposable.
Oh,
it's like-
well, that's an awesome thing.
It's like, on your side, we probably won't need except a scissor, needle holder, a hemostat,
11 blade?
11 blade.
Those are in the packs a lot of times.
11 blade is also disposable.
Yeah, but they're all in the pack if you got.
Yeah, it's a package, it's a small package, it's not a big package.
Okay.
That's what we're talking about. It's,
For any of the things
On
that you
your
want to
side,
do here,
huh?
for any of the cases that you want to do here, is that, you know?
that is
simple?
all what we're gonna do right now
Okay.
is involving very, very minimal, sterile processing. About 95 to 99% of the stuff on the kit are disposable. You use them and you throw them away. Like I said, on your side, actually the kits are also disposable. I mean, like for example, this, probably all what we need is like the suture kit that they use in the ER, which
Those,
is,
a lot of that stuff
Is, yeah.
needle driver, scissors.
yeah, it's all,
that stuff.
it's all in the kit and you use it and you throw it actually.
Okay.
Packs like $20.
Yeah.
It's got your trays, it's got your bowls,
Yeah.
it has all the stuff.
Okay. That works.
So, it's very easy. It's very easy.
I'm liking it.
Start, yeah. Once we do start doing surgical procedures, then that's a different game, but that's, I don't think it's gonna be done here anytime soon. What we're talking now is percutaneous procedures.
Dr. Abbas, are you gonna be bringing your fellows and residents over as well?
We might, We might, and I know the general surgeons bring their residents, and I don't know if they have fellows, but the residents are done here. Yeah, so we might, yeah, I mean, if we reach a full day and it's useful for them to be here, seeing these stuff, yeah, absolutely. For now, probably I can tell you for sure, for July, no. As we progress, I do not know.
I just saw him walk down the hall.
Where's Louis?
Yeah.
He left.
He is a travel nurse, right?
He never
I
settled
just
on
saw
the
We
him
need
job.
to
walk.
text him and tell him to come back.
I know.
Any issues, I'm gonna look
He'll
for
be
a
here.
recovery doctor to come out to me. So any problems, I'm looking for a recovery, they go out to me. So that can alert you to.
No.
No?
No, it's very, very easy care. It's very easy care. They come out, they do well. It's not like the angiogram even when you stick in the groin. It's mainly venous system. Venous system are low pressure system. The rates of complications from sticks and from accessing the venous system is very low. I mean, I don't want to jinx myself now, but usually accessing and intervening in the venous system has a low complication. You're dealing with like some of the most benign procedures. It's kind of pretty close to like colonoscopy and biopsies. How bad is colonoscopy and biopsy?
Pretty good.
You do it here, don't you? If you can do that, you very easily can do a fistulogram and angioplasty. I mean, do you need anesthesia for colonoscopy?
Yeah.
Unless-
Sometimes.
Really?
Oh, I definitely do.
No, I mean CRNAs and.
Yes,
Some do.
they do.
Oh, really? I
Yeah.
didn't know that, yeah. I had mine without anesthesia.
I'll do it again.
I had an AUT without us.
Not ever.
Okay.
Anyone have any questions? We had a couple pre-op nurses join us, I
Did
see.
we miss something? The pre-op? Did we miss anything?
He said most
No
patients,
No,
no IVs.
That's the main thing. Listen, these patients, you stick them, and they have difficult access.
That's what we're
The-
assuming.
Yeah, because their veins have been used and used and abused and abused and abused. And what they love about outpatient centers is they don't bother them with IVs. And usually the IV is their access. Once we put the sheath in, that's their, it's a very easy access. And the problem with you guys here in pre-op is that you're not allowed to use the arm with access, so you have to go to the other arm, and usually the other arm is very difficult, so that makes your life much difficult. But if we tell you, don't worry about it, and even in the hospital, when they call me, I'm not able to get an access on a patient, I tell them, you shouldn't have even tried.
Okay.
Just leave it for me, I'll take care of it in the procedure. And I was telling them before you came, I get access and I shoot even the first shot without even any sedation or anything or any medications. And if I know that I want to intervene, they know, the nurses know me by now, they immediately drop the medications on the table and I give it all. We have to make it easy, smooth, a nice experience for these patients, for them to come back, for them to trust us, for them to, we don't want to make it difficult for these patients, trust me. If they like it, they will start asking to go to a place. They want an easy in, easy out place, nice people. These are, you have to understand, these are people that go to dialysis every other day. Their life is pretty much, their social life is like dead because they have to be in a dialysis center every other day. I mean, imagine you have to be 4 hours hooked up to a machine every other day. So the easier we can have it for these patients, the smoother, the nicer the experience, the more our center will be competitive. Because they do it very well in other centers. They do it very well.
Any other questions? Steve, Tony, do you guys have anything that you'd like to?
Unless you have any questions.
They'll be around when we start this. And I am sure questions, concerns will rise as we go through the process. And it's never like, okay, we're gonna take off high. I mean, we hope to take off high, but there's always, a learning experience. This is not gonna be a very hard learning experience, I can tell you. It will take probably a couple of times and then you'll feel much better with it. I mean, I don't know who of you worked in a cath lab or in an IR place. You worked with us.
So that's what Tony and I did before this. I'm a nurse and Tony's a tech, so we've been sitting right there. We've been doing this for a long time, so got all your bases covered.
I mean, did I say anything wrong or anything? Tony, I think, was at UT cath lab, and then he moved to St. Luke's cath lab. Yep.
And I worked at St. Peter's for 10 years.
Okay.
Yeah, if there's any other questions, come up afterwards, we can know how to get hold of me.
Mhm.
Dr. Abbas and I talk all of the time, he's in my office, believe it or not, every day.